This team is led by Dr. Iggy as well as Dr. Michael Krautz. And you've already heard about Dr. Iggy, but Dr. Krautz is Professor of Psychiatry and Leadership Chair for Addiction Research at UBC. And he was also the PI of several paradigm-shifting clinical research projects, both in Germany and Canada for the last 30 years, such as the Salome trials and the Chez Soi Vancouver site, part of the trial, and other major trials as well. Also on our team, I also want to acknowledge a number of experienced psychiatrists, researchers, as well as addiction specialists, and their names are also listed here for those who are co-investigators in the project. So I'll talk a little bit about what we'll be covering in our time today. In the next slide, perfect. So we'll be talking about this innovative new project, starting with a bit of background about the role of fentanyl, its history and impact in healthcare systems. And then we'll talk about the goals and objectives of our project. And then Dr. Iggy will take it away and talk about the complex kind of methodology that we have planned. And then lastly, the expected data we hope to collect, as well as the impact we hope to have in the field. So we'll start off with a bit of background and context on fentanyl and its role in drug markets and impact in the healthcare system. As most of you are aware, the opioid crisis has become increasingly prevalent concern in Canada. And according to the Canadian Centre on Substance Abuse and Addiction, there are on average 12 opiate-related deaths per day in 2020. And according to the Government of Canada, 96% of opiate-related deaths are accidental, so not related to an intentional attempt to end one's life or anything like that. And mortality through opiate overdoses in Canada is extremely concerning, and healthcare systems is currently struggling to respond effectively. The opiate crisis is actually driven by many complex factors, and one of those is contaminated illegal drug supply. And fentanyl has become the dominant street opiate in North America, and having largely established itself in the drug market since 2015 and become the drug of choice for many individuals now since 2019. The illegal drug supply has become increasingly contaminated with fentanyl, which has increased the risk of accidental overdose, even if you're not using fentanyl or any opiates as well. As one of the most potent opiates currently known, it has also become the most important contributor of the current overdose crisis in recent years, which has only continued to worsen with unprecedented fatality rates. Now, I'm sure most of you have heard about fentanyl, but more recently, we have synthetic opiate derivatives such as carfentanil, which is 100 times more potent than fentanyl, and that has emerged on the streets. And this, in comparison to morphine, is actually 10,000 times more potent. So as you can imagine, now with all these new substances, it's very difficult as someone who chooses to use substances to figure out what amount you're using and even the drugs that you're getting access to. Another interesting change that we've seen is the presence of non-fentanyl derived synthetic opiates, such as nitazene. And these developments represent upcoming challenges to the systems of care, which are already felt in hotspots, mainly here in British Columbia and Canada, but also in other North American cities as well. To give you some idea of the numbers around this, from 2020 to 2021, the number of overdose deaths involving fentanyl remains super high with a positive toxicology of 85%. But the presence of carfentanil approximately tripled in just this 1 year alone. Now, there have been many initiatives and programs implemented to respond to the current crisis. BC government has initiated different legal intervention measures from 2020 to 2021. For example, the Safe Supply Program, funded by Health Canada, organized the distribution of highly potent different psychotropic substances outside of a therapeutic context to reduce overdose. So for example, you can access hydromorphone safe supply and be provided with 8 milligram tabs on a pretty regular basis. And although advocates praise this change, I think it's really important to note the, lack in emerging research in this area. And really the current available evidence on its effects are only available on a case-by-case basis. And we're collecting data slowly, and the research is coming out on this as well. However, to help the system of care respond to this dramatic situation, it's actually quite critical to understand the dynamics, including the effects of current measures over time, which is partly what our study intends to achieve. So some changes we hope to see happen are to include further research and data collection in order to ensure that any advice and policy changes are actually evidence-based. For example, all domains of care, from safe supply to emergency response and acute inpatient care to the community maintenance and adjunct therapy, such as counseling, need to also be evaluated. They also need to be adapted given the high mortality risk in this population and the ever-evolving potency of substances on the streets as well. Furthermore, a new system of prevention and early intervention needs to be built. In particular, the youth population is vulnerable to the effects of fentanyl use. And so identifying effective key interventions early is actually really important. And thirdly, we hope to highlight the fact that the overdose crisis, while at the moment is really contained kind of within North America for the most part, is not likely to stay this way forever. As global distribution networks grow stronger, it gets easier to create and distribute synthetic opiates. And we may start to see similar issues in Europe, in Asia, and Africa, perhaps. And therefore, it's important that we investigate and create solutions that work in order to anticipate the global epidemic that this issue may become. Next, I'm going to talk a little bit about our goals and objectives and what we hope to do with research. So one of our most important study objectives is to analyze overdose-related mortality related to engagement in the treatment system of care for people who use drugs, with fentanyl as the primary drug of choice. And in doing so, we want to firstly identify people who choose to use fentanyl as their primary drug of choice. And this is in order to firstly identify details about their use patterns, such as risk factors, preferences, changes in behaviors, routes of administration that's preferred, as well as to understand overdose histories and ways to prevent overdose. We also hope to identify the ways that people use substances interact with the health system. So for example, in their needs of care, in treatment and management preferences, perceptions on safe supply and acute care in hospitals, and positive and negative interactions with the system of care as well. The collection of longitudinal data will also allow us to determine the significance of risk factors and the effectiveness of therapeutic interventions related to the management of opiate use and prevention of overdose fatalities. Now, we have also sought to bring in sex and gender considerations in order to be cognizant of the biological, psychological, and social cultural identity factors that influence individualized behavioral consequences. And our goals include analyzing both risk and protective factors that lower survival rates. And to do this, we will seek to specifically actually recruit minority groups, both as participants and also partners who identify as Indigenous, LGBTQ+, women, as well as young adults. The project goal is to equip the system of care with the evidence to stop the increase in mortality among opiate users through the development of effective interventions and protocols based on appropriate models and settings of care. And with this, I will turn it over to Dr. Iggy to talk about our methods and details for the project.
So thanks very much, Dr. Tsang. I will maybe just take a quick step back and let everybody on the Zoom call today know that we are in the process where we are at with the research, and that we are in the process of developing the actual methodology, working on ethics application and the study tool. And then from there, we'll start the recruitment. So we're presenting the concept of the project and what it is that we're working on and what the group has put together at this point in time. I don't have any particular evidence for you at this point. Excuse me, feeling a little under the weather today. You can go to the next slide. Okay, so the project that we are proposing will use a prospective longitudinal observational cohort study design. And we plan on doing this in a couple of different ways. So first, we intend to recruit individuals who identify that fentanyl is their primary drug of choice. And so using a cross-sectional analysis, we want to start with learning about their patterns of substance use over the previous 2 years, how that has shifted over time, the frequency, the administration, the dosing, et cetera. And then following the cross-sectional assessment, actually having the ability to follow them longitudinally for additional 2 years, documenting various events, including overdoses, hospital admissions, treatment interventions, and also better understanding the impact of any related therapeutic initiatives, such as Dr. Tsang mentioned, safe supply, detoxification, residential treatment, and interactions with the healthcare system in general. And in order to recruit a generally representative population of the general population, we want to make sure that we're recruiting from different settings. So not just the acute community or acute hospital, but also thinking about community care. So partnering with individuals that work in housing programs, thinking about individuals that are in maintenance and maybe more established in their recovery, and also thinking about acute inpatient care and tertiary care. So thinking about trying to recruit individuals from the entire spectrum of the healthcare system. And we've made some very strategic partnerships with various hospital settings, including BC Children's and Women's Hospitals and others, in order to think about recruiting some of these vulnerable populations who are frequently underrepresented in the research to be able to better understand how these groups compare to other individuals. So the methods that we propose for our data collection is to explore, as I said, an initial baseline assessment using an assessment tool that's in development. This will be a questionnaire, a survey that will be administered to the patients, better understanding their previous history over the past 2 years, and then continuing to observe longitudinally over the next 24 months. And the questions that will be included in this survey will include, as I mentioned, information about their substance usage, and particularly opioid and fentanyl usage and history, overdose and other risks that are posed with ongoing opioid usage, including smoking or injection drug use, and also better understanding of mental health, medical, social, and other individual characteristics and factors. From there, we plan to periodically follow the patients and contact their families actually over time with individual patient permission to better understand what has the experience been over time, in order to prevent, and this comes out of a recognition that there are very high rates of loss of follow-up for some of these individuals who may be transient, may be marginally housed, may not have access to reliable methods of communication and other things. So how can we better understand what is happening with these individuals over the spectrum of time? We also intend to request consent to use administrative data. So when I say that, that refers to things like the BC coroner's data, things like ambulance records, and other governmental databases, in order to understand what are the touch points with the healthcare system or the system of care that may not be directly identified through the hospital, for example, so that we can really have a very comprehensive understanding of what are the systems of care that these individuals are accessing, and with the idea that that over time may actually help us build new models and new systems of care, thinking about creativity and innovation, which I think is going to be very necessary in order to make a dramatic shift in the opioid overdose crisis. So in addition, we intend to use phone interviews if patients give us permission, to consider accessing social media to provide check-ins and other ways of contacting. And as I mentioned, the family and peer consultations as well. And we use a platform that's called the Risk Assessment and Management Platform that was developed by Dr. Kraus and his colleagues, and that will be provide check-ins every 3 months. You can go to the next slide. So this is just another visual of the timeline that we're anticipating that this will happen over. So as I mentioned, currently between 2021 and 2022, we've been working on grant applications. So through the Canadian Institute for Health Research, we've been applying for grants in order to fund what I anticipate will be a resource intensive proposal, and over time work on developing the assessment tool and ethics proposals. We intend to initiate the cross-sectional study at Vancouver General Hospital with a pilot study with a smaller group of individuals to understand the feasibility of the study. What are we identifying in terms of ease of the study assessment? What challenges are we running into, so that once we launch across Canada and at other sites, we will be able to iron out some of those potential wrinkles. And so we anticipate that in about 2023, we will be able to start the BC Fentanyl Cohort study at VGH BC and actually expand that further across Canada with partnerships in Alberta, in Ontario, and working on recruiting partnerships in other sites across the country. Part of our goal with this study is, as I mentioned, the 2-year period of time to follow individuals longitudinally. However, that's a long timeline to wait for information and to analyze the results of what it is that we're finding. And so one of our intentions is to be able to actually throughout the study at key points, review the data, analyze it, and be able to have interim analyses of the cohort study in order to provide that to the stakeholders and other internal partners. And depending on the information that we are identifying and how that may be helpful, ensuring that that information isn't being, sort of in isolation, but that's being able to be transmitted to individuals that have the possibility to engage in making meaningful change. So that includes stakeholders in the hospital settings, in other treatment facilities, and across that entire spectrum of care, including policymakers. We anticipate that the study will complete in about 2025 to 2026. And at that point, we'll plan on providing final reports based on the analyses and the information that we do identify. From there, the next steps of the project will occur, in which we'll really be planning on identifying knowledge translation consideration. So that means based on the information that we have identified, the risk factors that we've identified, the patient satisfaction and preferences that we have identified, what impact is that going to make to the existing healthcare system, and how is that going to allow for a positive and important change over time? Next slide. So I'm going to talk a little bit about some of the outcomes that we are anticipating and how we anticipate that this will be able to apply this to the healthcare and community settings and the significance of the data over time. The next slide. So our hope and ultimate goal is that this information, this epidemiologic, retrospective and prospective longitudinal data, will create critical evidence to inform the development of existing and new effective treatment protocols that over time will allow for the mitigation of threat of opioid overdose by understanding changing patterns of use and how this impacts existing treatment models. So using the longitudinal data, we anticipate that the significance of this information will help us identify individual as well as population level risk factors, better understand the ease of access or the challenges with accessing effective care. And that could mean specifically substance use care, that could mean specifically harm reduction care, that could mean the spectrum of detoxification or residential treatment, but also access to concurrent disorders, which as a psychiatrist is a topic that's very near and dear to my heart, and something that in British Columbia is something that we are still on the precipice of really being able to prioritize and better understand and serve our patient population. And all of this over time will allow for comparison of overdose survivors versus non-survivors to better understand what coping strategies or interventions have been impactful, and thinking about how do we adjust these, or how do we make these more widely accessible to the to people who use drugs, and particularly opioids and fentanyl as their drug of choice. Our third expected outcome is an ongoing and improved understanding of the shifts of street drugs or the illicit drug supply, And at this point in time, a lot of our data collection has been quite reactive. The BC CDC is doing a really wonderful job of collecting information about the drug supply based on patient testing, and is analyzing that and is putting out that information quite continuously. And so that will allow us to restructure and adapt the system of substance use care through all of those different levels of care that we had talked about, from detox to acute and emergency responses, maintenance of treatment, and also abstinence-oriented rehabilitation. Next slide. And so I think, not surprisingly, the overarching goal that is the driving force behind this proposed project is to reduce the number of overdose cases, and perhaps secondary to, and perhaps overarching even to that, is to decrease the mortality that individuals who use opioids, particularly fentanyl, are experiencing, and to make a critical push to decreasing that over time. The way we anticipate that will happen is through the epidemiologic data that is collected, and then identify and implement new treatment systems to meet the needs and expectations of people who use drugs, to help with retention rates in hospital, to think about, I'm sorry, not just in hospital, in treatment in general across the spectrum, to think about innovative and new treatments, both from a pharmacotherapeutic perspective to psychosocial interventions, to wraparound and housing needs in order to stop the ongoing increases in mortality rates that we continue to see year after year. Next slide. And so, just in summary, before we open up for some questions, discussion, commentary from the group, any particular thoughts that you have, I just want to summarize that our intention is to follow the highest risk cohort of people who use drugs locally in British Columbia and across Canada, to better understand this population, who represents a new and rising demographic. We plan to do that using longitudinal data collection. And one of the potential outcomes is that this can be used as an ongoing monitoring strategy through the reliance on administrative data, systematic toxicology, and also will allow for monitoring of new substances. And over time, to evaluate the response to the overdose crisis and inform the reasons that this is an ongoing struggle and poses challenges to the existing system of care, with the overarching goal of reduction of mortality. Next slide. And so with that, I will pause. Thank everyone for joining us today and for the interest in learning more about the proposed research. Dr. Tsang and I will be available, as I mentioned, for questions, commentary, thoughts, and we're keen for feedback and any thoughts that you have.